Hey everybody, this is Eric with Motion Guidance. Welcome to this week's vlog. The topic is going to be utilizing the motion guidance system for assessment and treatment of the cervical spine joint position sense error. This is a really common topic and a requirement in clinic if you're seeing whiplash patients, concussion patients, and neck pain patients. I wanted to go over a few research articles first. The 2003 article, Dizziness and Unsteadiness Following Whiplash Injury, Characteristic Features in Relationship with Cervical Joint Position Sense Error. This is one of the classic ones showing that people with whiplash-associated disorder had more alterations with sensory motor input and joint position sense error input. But in 2011, Rob Landell took that data and he created this target, put the reference on the slide for you down here. Essentially, when they were doing the joint position sense testing, everything in the yellow and the green was inside the standard deviation, the red or beyond was outside the standard deviation, and that's how we started to be able to tell from a diagnostic standpoint who was having joint position sense issues. The second article coming up here, same author, 2017 JOSPT, Dizziness, Unsteadiness, Visual Disturbances, and Sensory Motor Control in Traumatic Neck Pain. They actually put a laser also, instead of just on the head, on the torso to help aid them in knowing how much movement was being created and where. But what she found was less accuracy in tracing patterns for those with traumatic neck pain when compared to both the control group and idiopathic neck pain in this particular study, suggesting not only joint position sense things, but also motor tracking and motor patterning issues that might need to be addressed within that population. And the traumatic neck pain tends to sometimes correlate with also whiplash-associated disorder. Two other quick studies that were systematic reviews, one in 2015 here in Manual Therapy. Essentially, the take-home message was when they reviewed the literature, those trials that included at least 6 repetitions of trying to assess whether a joint position sense error was present were better than those that were just assessing 3 at a time. So we're going to go through those in a little bit later about how that's relevant in how many repetitions you perform with your assessment and how many you might want to consider doing also for your treatment. But there was a second study that found the same thing, 2010, irregular head movement patterns in whiplash patients during a trajectory task. Also found that a minimum of 6 repetitions was needed to find this joint position sense error to be observable for clinicians. So the combination of these two studies really leads us to at least include 6 repetitions when we're looking for joint position sense issues within the neck pain population, the whiplash-associated disorder population, and even in the concussion population. Good idea to perform this testing. So if we start to get into how to utilize the system, you can use one of our medium to large size belts. You can put that on the patient's head with the head cradle, and then the perpendicular mount with the laser put on top of that. You can use the red or the green laser for these. But we're going to do 3 practice trials with the eyes open and then 6 clinical test trials. If you have 3 positives that are outside the standard deviation, then you're going to diagnose them with a joint position sense error issue. Our target, if you look on the flag here, the deep blue, that's in all of our flags that we've ever created, so you'll be able to use that, and we go 100 centimeters from there, which is about 40 inches, where the patient, the crown of their head is placed, and you have them look right at the target. Then you adjust the laser to be inside the center of that target, and then they perform repetitions. So 3 practice repetitions, always coming back to the middle, always encouraging them to look as far as they can over their shoulder with each repetition, and then you do 6 repetitions with eyes closed. During those repetitions, you note whether the laser is inside the standard deviation or it's not. So it doesn't have to be bullseyed. If it's going to be outside the darkness of the dark blue area, that's going to be outside the standard deviation. If it's anywhere inside that deep blue field, including the bullseye, then it's inside the standard deviation. So we're not necessarily looking for how tight the cluster is, just whether it's a positive or a negative. After you do the Sanders stuff, it's really common, especially with progressions of patients' home programs and work inside your clinic, to go through cardinal plane motions, other ones, flexion extension, go through quadrant plane motions. Can be super beneficial, especially for more dynamic work, sport, or ADL activities. So I hope you consider those. I hope this information gives you more outcomes in your clinic that are positive, and contact us with any questions.